Welcome again everybody, this is Yasser Al-Wasifi from Learn Dental series. Today we will continue our discussion about diagnosis and treatment planning in operative dentistry. I would like first to declare that I don't receive fees, compensation or royalties from the sales of any of the products shown or discussed. Also, I declare that this presentation has not been sponsored by any company, agency or organization and is only prepared for educational purposes. This presentation is copyright protected and could not be transmitted by any means unless you have a prior permission from the author. In this episode, we will continue the proper diagnosis of tooth defects related to restorative dentistry and chief complaints related to restorative dentistry. As we discussed before, we discussed patient assessment and information gathering, and we started clinical examination in terms of examination of dental caries by all techniques, including advanced caries detection techniques and caries risk assessment. We already examined any existing restoration for any defects, and in the last episode we already examined other tooth defects. In this episode we will discuss all the adjunctive aids that we could use or we are in need for examining teeth and restorations, including percussion test, palpation, thermal test, electric pulp test, test cavity, anesthetic test, and finally periodontal assessment, which is an important type of examination we are in need with all our restorative management. As we said, these adjunctive tests are useful when further information is needed concerning the health of the teeth and supporting structures, including percussion, palpation, thermal, electric test, test cavity, anesthetic test, and finally periodontal test. Let us start with percussion test. Percussion test is by performing a gentle tapping on the occlusal or incisal surfaces of the teeth by the end of a mirror, or the handle of any hand instrument, just to detect if there is a pain or percussion that suggests possible injury of the periodontal membrane from the pulp or periodontal inflammation. I would like to notify that percussion is done either vertical or horizontal. Vertical by tapping on occlusal and incisal edges just to examine the periapical area, and lateral percussion or horizontal percussion to examine the integrity of periodontal fibers or periodontal ligaments supporting the teeth. We should take care when tapping and interpreting any positive response, which is considered as painful response to percussion when examining maxillary teeth, especially premolar and first molar area, because in some patients who are suffering from chronic sinusitis, they may elicit pain on percussion due to sinusitis rather than periodontal or periapical affection. That's why we should record the medical history of the patient carefully and in full details and asking about sinusitis in such cases. And don't take the pain on percussion for granted that there is a periodontal or periapical condition when examining premolars and first molar in maxillary teeth. Percussion also should be done out of sequence, because if you are starting from the central, then lateral, then canine, then first and second premolar, when you are approaching the offending tooth, the patient will be ready to feel pain. That's why it should be out of order, out of sequence. You are trying much more teeth than the offending teeth, and just let us say the patient having a pain which we would like to diagnose it by percussion, related to lower 5, lower second premolar. Then just tap on central and refer to upper molar, then coming back to the lower one, then coming to the offending tooth and trying to distract the patient to diagnose properly the painful response to percussion. Otherwise, if you are going if you are going in a proper sequence or order, then when you are coming near to the offending tooth, the patient will be ready to respond even if there is no pain. Positive response to percussion may indicate partial or total pulp necrosis, periapical lesion including apical periodontitis or apical abscess, lateral periodontal abscess, recent high restoration, or tooth undergoing rapid orthodontic movement. Considering number 2, periapical lesion, if the patient is suffering from apical abscess and you could notice an intra or extraoral swelling and all your data is directing you toward apical abscess, it's unhuman to tap on the teeth while you are already sure that there will be a painful response because it will be a severe pain. If you have all the signs and symptoms, if you have all the history, including patient chief complaint and the history of chief complaint that indicates that there is an apical abscess, also if you notice swelling either intraoral or extraoral denoting or ensuring that there is abscess, it's unhuman that you tap on a tooth that will elicit a severe pain in this condition, and you are not in need to do this. Okay, then coming palpation test. Palpation test is indicated if a pulpal problem is suspected and the tooth is slightly sensitive to percussion. In such a case, after viewing all the area carefully and clinically examine all the soft and hard tissue, palpation is performed by just rubbing your index finger along the facial and lingual mucosa over the region of the periapical area or the abscess, just to feel by tactile sense what is the sense of your pain or what is the sense of your area. An alveolar abscess in an advanced stage and some forms of cystis may cause tenderness on palpation. Sometimes the abscess is advanced but still not causing any swelling either intra or extraoral, but when you are pressing against the tissue palpated by your finger, it may show tenderness on palpation. Also, as this palpation will also reveal non-tender swelling. In certain cases where abscess is present and you clinically manifested as a swelling, sometimes it is beneficial to feel the tenderness and fluctuation of pus under your fingers, in palpation, in order to exactly determine the intervention if it is ready to be incised and drained or still not yet. Then coming the thermal tests. All of these thermal tests aims to indicate the pulp vitality, and we will comment on this. It is not a vitality, it is a sensibility, It can be conducted by either a small rod-shaped piece of ice, can be made by freezing water into an empty anesthetic cartridge, by using cold ethyl chloride soaked cotton, pledgets, or by using hot Guttaberg, But the most reliable is thermal method is a hot or cold water bath, under complete isolation with rubber dam, Responses to thermal test may be to hot and cold testing, just feeling a little bit hot or a little bit cold, It's a normal response when it is subside within few seconds of removal of the stimulus. Pain which lasts after application of hot and cold and removal of the stimulus for approximately 10 seconds, duration. That means that it is removed after a while, after you removed or lasts for a while after removal of a stimulus, indicates hyperemia or reversible pulpitis that should be considered during your treatment plan if the tooth need what is called restoration. It's a temporary restoration just to relieve the hyperemic condition of the pulp after removing of the cause shortly. But intense pain for longer duration from ice actually suggested irreversible pulpitis. Pain that results from heat but is quickly relieved by ice also suggested irreversible pulpitis. Then irreversible pulpitis or irreversible symptomatic pulpitis could be indicated when thermal test was hot, okay, relieved by cold, then you may suggest irreversible pulpitis. Also, if pain that lasts longer duration after application of ice also may indicate pulpitis. Lack of response to thermal test indicates non-vital tooth, okay, or non-sensible tooth. Then comes electric pulp tester. Electric pulp tester is a mean of testing the pulp vitality through the tingling sensation felt due to low electric current. Okay, when the tooth shows no response or the tooth didn't feel any tingling sensation, okay, that means that the tooth is non-vital and your sensory nerves are damaged. Okay, but if there is a response, that means the tooth vital, but it should be compared to a neighboring or contralateral, what is called reference teeth, that should be a healthy one, and at the same time, as much as possible, should be of the same pulp morphology. And then compare the result of this sensibility. Is it the same? That means that, or suggests that the tooth is normal. Is it early response, okay, to that of normal one? Then the tooth may show hyperemia or reversible pulpitis, okay, and also may show symptomatic pulpitis. If it is delayed, then it may suggest that the pulp is undergoing necrosis or degeneration, okay? But this is not a decisive method, it's also a conclusive method. You should gather all the information to decide if the pulp is diagnosed as vital or non-vital pulp. The problem in your electric pulp tester that it is not suitable for testing teeth with large restorations or teeth with full coverage. Large restoration, either it is metallic, it will conduct electric current in a faster way, or non-metallic, it will act as an electric insulator. The same for full coverage, and especially if your restoration is extended subgingival, then you will not differentiate between the tingling sensation from the gingival tissues, okay, or from the pulp of the teeth. And the tooth should be absolutely isolated, absolutely dry, just only with some devices you are in need just to use electrolytic gel. But nowadays, there is no need for that. Also, you should review the medical history of your patient, because these devices are not recommended to be used in patients with pacemaker, artificial heart pacemaker. This is a photograph of a pulp tester that denoting a reading that should be compared with other healthy teeth as we discussed. Then comes a test cavity. What is a test cavity? Test cavity simply, in certain cases, we have a problem with teeth with large restorations or full coverage that are not suitable to be definitely diagnosed with hot and cold or thermal test or with electric pulp tester to define the degree of pulp sensibility. In such cases, there is an old, from my opinion, aggressive, and also from my opinion, it's unethical test. That's why the photograph is in black and white, because it is very old and not used and rarely used nowadays, okay, just to test the pulp vitality through heat generation of burrs, okay. They recommend the use of round burr at low speed without coolant just to detect the sensibility of the tooth, okay. If there is no response, okay, that may indicate the pulp is non-vital. If there is a response, it may indicate the pulp is vital. But in such a condition, you should consider that this test by itself may induce pulpal problems. The same as hot gut aversion. That's why it is not recommended nowadays, and it is better to use hot water bath in a completely isolated field. Okay, by itself, those are considered as insults or stimulants. They may elicit pulpal pathosis. Okay, that's why it is not recommended at all nowadays. Please take a note that heat cold tests and electric pulp tester are tests for pulp sensibility. Why? Because they indirectly determine or give an idea about the pulp health by assessing the condition of the dental pulp nerves. That's why it is termed sensibility. We are measuring the sensibility of pulp nerves. But the term vitality, the true vitality, is related to the blood flow and how much it is oxygenated. Okay, that's why pulp vitality is a direct assessment of pulp blood flow. That's why it is considered as direct assessment of the pulp vitality. This is the difference nowadays, according to the American Endodontic Association, okay, that we are using pulp sensibility, not pulp vitality, because pulp vitality is measured by other devices like laser Doppler flowmetry and pulse oximetry, okay, which are now used to measure oxygen level at blood in patients with positive COVID-19 tests, okay, just to follow up the oxygen tension, okay. Why clinicians or dentists in general perform sensibility test rather than pulp vitality test? Because these devices with their application is limited in dentistry and they are difficult to be specifically used or specifically adjusted in dentistry. But it is actually available, okay, but it is expensive and not easy to be used. Followed by anesthetic test, which is a useful one when you have a referred pain, especially if you are clinically examined a patient and you could note that more than offending tooth in this quadrant. Let us say if we have a patient who is suffering from severe acute pain, okay, in the lower right side, okay, and when you are recording your history, you definitely expect that you will find a deep caries or a state of pulp exposure by a way or another. Okay, this may be from the history. You are directed to this area that I am in between deep caries or pulp exposure. Okay, and you hope when you open his mouth for clinical examination that you will find just one tooth. But the problem is, okay, you didn't find by visual examination or tactile examination any cause for this pain. You didn't point out what is the offending tooth because all teeth seems to be sound or because all teeth are severely damaged. But I would like to start with managing the chief complaint or the tooth mostly causing this complaint. Otherwise, if I'm treating a wrong one, I will complicate the condition rather than solving the patient problem. That's why we are in need for what is called anesthetic test. What is meant by anesthetic test? It is injection or localized injection to certain areas, and you are searching for the tooth at which the pain disappears. That means that the tooth that is responding to local anesthetics. That means that this is the tooth sourcing the pain. This is the offending one that I should start with. Although I should also stabilize and control the condition of other teeth, but I should start to stop pain because this is called emergency phase. Emergency means that you are dealing with either pain, bleeding, or emergency. Regardless the definite treatment plan, but emergency, you should stop pain, control bleeding, control infection. That means that emergency, okay? That's why we started to anesthetize, okay, with infiltration, the offending, the expected teeth, unless we find a tooth where pain subsides after injection, okay. You should start from the midline going posterior. You should start from anterior to posterior, because if you started from posterior, surely the pain will disappear without knowing which is the offending tooth, because you are anesthetizing the main root of your nerve, posterior superior alveolar, okay, or whatever the technique you are using, okay. If you are injecting from the most posterior one, then all the anteriors will be anesthetized, and it's not vice versa the same, okay. That's why we started with just the infiltration, okay, buccal to the teeth, or maybe sulcular injection, okay, intrasulcular injection, okay, few drops, and waiting for the response. The only problem of this test is it is a time-consuming one and multiple injections in the same quadrant. But also, most of the acute cases, okay, the cause will be obvious. It's a very rare case, rare cases when you are in need for this. This comes one of the most important adjunctive aids, okay, which is the periodontal assessment, okay. Because of the obvious importance of the periodontium, operative procedure must be performed continually with respect, understanding, and concern of periodontium. The problem is, as you see in this picture, patient says they floss daily, but actually there are some clues that tell us otherwise. The problem is in the concept of oral hygiene measures, okay, and how it is important, the difference in the concept between patients and operators. In such a case, I would like to ask you how to solve these problems. Number one, how to diagnose the presence or absence of cervical lesions or defects. Already the cervical area is covered by dental plaque, okay? Is it a plaque, or is it a demineralization, or both? Demineralized cavity or cavitation, starting cavitation superimposed by plaque and deposits or calculus. Number two, how you accurately determine the cervical extension of your lesion, and that's why you could note in the lateral one, okay, that the cavity is more than or higher than the cervical area, because the operator couldn't determine where to stop, okay. He couldn't determine where is the exact extension of his caries. How to decrease the liability of bleeding during cavity preparation and during bonding procedures of the material, and how you could determine the shade and the color, okay. This is a great problem unless you are, number one, restore the health or periodontal health, okay, and the patient having a good oral hygiene, okay, you couldn't start your restorative management. In such a case, if the patient is having an active caries like this case, just excavate it, okay, temporize it with GIC, because at least it has a fluoride releasing capacity, and at the same time it has multi-shades that could to some extent solve the problem of aesthetic temporarily until you maintain a good oral hygiene and the patient followed your instructions. But in such a case, let me show you this area, okay. The same, it is from one of my students. It was a CC case, comprehensive clinical dentistry case of Ahmed Al-Juhani. He is now a specialist, a dental specialist at Saudi Arabia, okay. At this case, how could you match the shade? How could you determine the cervical margin of your caries? Is it a caries or not? All of these should be assessed. For proper assessment of periodontal tissues, it could be done by visual tactile examination or by radiographic examination. You are examining the presence of black debris and inflammation, and the general level of home care must be noted and recorded in your history. Okay, why? Because the teeth cannot be properly restored, as we mentioned, while surrounded by debris and hemorrhagic tissues or debris. Okay, and the gingiva at this time should be sufficiently healthy for the success of your restorative procedure. Also, as a long-term prognosis, any operative treatment is highly dependent in its prognosis in how much your patient could keep the restoration clean, and this could be performed parallel to or in line to with maintenance of oral hygiene by prophylactic measure. Otherwise, the environment will be unfavorable for the success of your restorative procedure. That's why you should note visually that you have a healthy gingiva, which is light pink or pale pink, firm in texture, knife-edged, and has a stippled surface, while unhealthy gingiva is red, soft, with rounded margin and has a glazed smooth surface. Also, by tactile examination using periodontal probe, you should monitor the depth or record the depth of your gingival sulcus around the tooth and determine it with a systematic probing from all sides. Okay, any sulcus depth more than 3 millimeters should be considered or recorded in your chart as a pocket. Also, gingival recession should be noted, hemorrhage should be noted, and tooth mobility should be evaluated to determine the degree of damage of your periodontal support. But please note that sometimes this mobility may be due to abnormal occlusal forces or due to eccentric occlusal habits. That's why it should be examined also when you are examined a tooth and you discovered a tooth mobility. It is not exactly because of periodontal problem. You should examine also occlusion of the patient. Okay, you should examine the pulp conditions. There may be a temporary periapical conditions that may result in this mobility. Not all tooth mobilities are related to periodontal assessment. As we mentioned before, it may be due to rapid orthodontic movement, okay, or improper stabilization, okay, or retention after completing orthodontic treatment. Then finally comes the radiographic examination. This is one of the most important examination for periodontal assessment, and already you are not in need for extra views for periodontal assessment. Your bite wing, exact bite wing with proper exposure, proper angulation is the best mean and the best diagnostic tool for radiographic diagnostic tool for assessing the periodontal tissues, especially the alveolar bone bevel. Okay, there is a localized or generalized bone loss. Is it a vertical or a horizontal one? Always vertical bone loss may be as a result of combination of inflammation or may be due to abnormal occlusal habits or eccentric occlusal forces. Okay, whether horizontal bone loss is only related to inflammatory process. Also, radiographs must be reviewed to determine relationship between margins of existing restoration or region, okay, and the bone level. This is an important issue for the success of restorative procedure and for the health of periodontal tissues. Because already we have what is called a biological width, which at least 2 millimeters, okay? It is the distance from the junction epithelium and connective tissues attachment located between the base of the sulcus and the alveolar crest, okay? The restoration margin should be as far away as possible from the base of the sulcus in order to maintain the gingival health and in order to avoiding encroachment of the biological wedge. If your restoration margin is encroaching the biological width, then the tooth will undergo bone resorption, periodontal damage, and will result in much more complications in a form of periodontal pockets and in a form of mobility, tooth mobility, okay, and all of these will lead to, by a way or another, to food stagnation and the ability of recurrent caries. That's why your restoration margin in case of compound cavities or proximal cavities, especially because we couldn't inspect the proximal area unless we have a radiographic bite wing view, okay, should not encroach the biological widths or should not violate the biological widths. That's why you should evaluate your case, okay, and where will be the proposed gingival margin, the extension of your gingival margin. In certain cases, sometimes your caries is already extended near to the alveolar bone and your margin will be or will violate your biological widths. In such a case, you are in need to examine your case carefully, consult a periodontist just for either surgical crown lengthening or orthodontic extrusion, or it is not encroaching the biological widths, but you are afraid of its depths. It is near to the sulcus, the bottom of the sulcus, but it is not encroaching the biological widths yet, but it is at the baseline, okay? It's at the deadline, as they said, okay, this is the at least margin. In such a case, you are not in need for surgical crown lengthening, but you are in need for deep margin elevation because this depth is not suitable or favorable for bonding procedure or for applying matrix or whatever the manipulation of your material. You could note that this case, okay, the schematic diagram is showing A is the biological width, which is the distance from the bottom of the sulcus up to the crest of your alveolar bone. Your restoration margin should not violate this width, otherwise the patient will suffer from periodontal problems, food impaction, and recurrent caries, in addition to great liability for tooth mobility. Also, we couldn't forget the sensitivity due to root exposure that the patient will complain from, okay? In such a case, you could note that the bite wing radiograph showing that this patient had undergone crown lengthening just to get the alveolar bone and the biological tips away from your gingival margin, okay, and to adjust the gingival margin. This is a clinical case showing that you have a defective mix of composite and amalgam restoration. Okay, when we removed it, we discovered that our margin will be extended or should be extended to violate the biological width. In such a case, the operator consulted the periodontist, okay, and surgical crown lengthening had been done, okay, just to cut a little bit of your alveolar bone to drive the biological widths away, okay, and get your margin higher, okay. In such a case, after complete healing, you could note how much your gingival floor is now clear, and you could apply your rubber dam, apply matrices, and go for all the procedures of bonding without irritate your gingival tissues and without your gingival tissues jeopardize or destroy all your bonding procedure. Another case, you could note that in bite wing, our margins seems to be at a lower level but not encroaching till now the biological depths, but we are afraid of that, okay. That's why we are at the minimal permissible level, okay. Our margin is just a little bit above the base of the sulcus, while we shouldn't go through more than half of the distance or 2/3 of the distance. In such a case, the operator apply a rubber dam after complete cleaning, okay, tissue retraction cord, okay, apply circumferential automatrix just to raise the bottom using resin modified GIC, okay, just raise your margin, which is called deep margin elevation, just to ensure proper bonding procedures, okay, with the tooth structure without irritating the gingival tissues and without the gingival tissues reduce the quality of your bonding procedures. This is called deep margin elevation. And you could note the radiographs, okay, bite wing radiographs. It is how much it is a helpful and useful tool in diagnosis and in following up this condition. That's why the decision making is a little bit tricky, and you should use all your skills in critical thinking. Decision making is it is deep margin elevation with resin modified glass ionomer, surgical crown lengthening, or orthodontic extrusion. And why resin modified, not conventional GIC with deep margin elevation? Number one, we should determine, okay, where is the proposed level of our gingival seat of the preparation. If it is near to the bottom, but still not encroaching or violating the biological width, then your problem is the bonding procedure and the curing of your composite. The area is inaccessible, okay? You may irritate the gingival tissues and you could not isolate properly this area and control fluid to get all the benefits and to get high quality bonding procedure. At this time, we are in need to go for deep margin elevation with resin modified GIC. Just backing retraction cord, well applied and well backed, and selecting proper size of our retraction cord, then applying resin modified GIC until we elevate the margin to the level of the crest of free gingival margin, and then going for the procedures for applying bonded composite resin restoration or even amalgam restoration. Okay, this is number one. If the proposed margins seems to encroach or violate the biological width, then we have either one of two choices: crown lengthening or orthodontic extrusion. The decision making in such a condition is the periodontist decision, not our decision. But in general knowledge, okay, there is a limit to reduce your alveolar bone, otherwise you are already distracting the bone support of the tooth. That is why you could evaluate what is the cause of this violation. Is it because the tooth is not perfectly erupted? That's why the margins of your restoration is in proper place, but the problem is your tooth is unerupted to the proper level. That's why at this condition the periodontist, or we may prefer orthodontic extrusion, and restore the tooth temporarily until orthodontic extrusion is finished. But if the tooth is properly erupted to the proper level of occlusal level, at the same time your gingival attachment and the relation between the gingival attachment and the crown and cemento enamel junction is in proper place, okay, not jumping over your cervical line, it is in proper place, then go for crown lengthening. But I still insisting that this decision is not mine as a restodontist, okay? It is the periodontist decision. Then coming, why resin modified GIC, not conventional GIC in deep margin elevation? Conventional GIC, although it has a better bonding to the tooth structure, and at the same time, more than that of resin modified GIC, at the same time, its fluoride emitting capacity is higher, but it is highly sensitive to moisture contamination, and its setting reaction is acid-based reaction that needs to be maturated after 24 hours. Okay, that's why we are using resin modified GIC, which is less sensitive to moisture contamination at early stages. Okay, its reaction is resin-based and acid-based reaction. Its resin-based reaction is a faster one, as we used light curing unit, which adds a command setting. Even it is a chemical cured resin modified GIC, but I could build the composite, okay, immediately at the same time, not to wait for 24 hours for complete hardening and maturation as that of conventional GIC. Finally, those are the textbooks that I recommend you if you would like to read much more about the adjunctive aids for diagnosis, especially that of Restorative, Art and Science of Operative Dentistry. Finally, feel free to ask me, as your questions are welcomed. You could ask me by commenting to this video and I will reply as soon as possible. And also you could contact me via my email, and also I will respond to you, reply to you as soon as possible. Finally, I would like to thank you for assigning this time to listen to me, and don't forget to like the video, subscribe to my channel, and activate the notification to get all the updates as early as possible. Thank you. Yasser Al-Asifi.